All right. There's a title. So I am going to talk to you from the perspective of one of these activities that Ian mentioned, which is Cantor Health, which is actually a 501c3 foundation that I'm very actively involved in. And there's another project I won't talk about today, but we can talk about over time. So the focus that I wanted to start out with is predictive modeling integrated in healthcare. And I'm going to move from that general perspective of the very tightly integrated things that we can do directly in healthcare to how that blows out larger into a learning health system. So that's the perspective. So as people in this room know more than most, informatics and predictive analytics has changed the world that we live in. And it's changed it across many things. These are sort of the commercial ones that affect us every day. There was a famous story about Target a few years ago being able to predict when people are pregnant. And this is an important story because it shows what happens when you take the power of these things and do it not quite right. And you can upset people, okay? And for many of you that know that story, it was quite controversial, but of course the algorithm was quite good. So all of these things are affecting things that we do every day. And of course at the bottom, near the bottom here, this really is science's third pillar besides theory and experiment, which is the use of data and computation. And I think that's what we're fundamentally talking about today. And the question that I'm going to begin to address is what about that in biomedicine and in medicine in particular? So the biomedical data universe is quite broad, and so this represents one of the initial problems. And we have this data that's lifestyle data, which is somewhat similar to what I was just talking about. There's environmental data that has tremendous impact. We know geographically diseases are different. Is that social? Is that the environment? What is that? We have the clinical, which is a very small, fine-grained, and actually relatively sparse set of data relative to some of this other data, but it's of high value in that it's data collected based on experts looking at a biological system and making very specific assertions. And then the genomic data, which on the other hand is broad and so much so that we don't even understand it all, but it has a very wide dynamic range in each individual, so much so that we then have the problem of having too much data that we don't know how to find the signal in. So we've got every kind of problem in the biomedical data that we want to drive from. And then of course we have this problem, which is the health spending as a share of GDP. The slide's somewhat old right now, but it seems to still be, I checked recently, maybe a year ago, and it still seemed to be marching from that direction of 2012 towards 2022. I'm sure Harold knows more about this, but I think it's starting to taper off a little bit, but it's generally still heading in this horrible direction. And then we have the physician, and this is one that is particularly from the point of view of an oncologist, which is really a bewildering problem, which is we need to make decisions within the context of an individual, and yet there's so much information coming from different sources, each of which have large error bars around them. And so we try to integrate that in some way, and it's sort of nearly impossible. But we do the best that we can. So that is an area where decision support is really needed. And this is one more part of the problem, is that based on the lens of the data that we have in this sparse clinical data, many patients look very much the same. And we give them the same diagnosis, but in fact when we start therapy, they go into different kinds of groups. They go into groups that never had the right diagnosis in the first place. Those that respond, which hopefully is the large proportion as it is here, and then some non-responders, but then there's toxic responders too. And so there's this whole problem of personalization in medicine and finding out those detailed biological characteristics or maybe even social characteristics or behavioral characteristics that actually lead to these different outcomes with the same therapy, starting with the same diagnosis. So in the Affordable Care Act, as mentioned, one of the things in there was tremendous incentives to put in electronic health records as part of the solution to all this, to begin to collect data where data was on paper. And so really that's been a huge driver, and this shows the effect of that over the last 6 years, going from some basic kind of electronic health record. In 2008, you had, in the neighborhood of 10%. And if you go back to, 2003, you get back to the, the 1 or 2%, and that's where North Shore University Health System, for example, put in the Epic EMR back then in 2003. And so there's just a tremendous lead in working those things out and all the workflows and all the things that drive care. So that's been a very special place where I've spent the last 5 years, and I'll mention some things that we've done there. But this is, almost an exponential curve, and then the S tailing off when you get up in the 80%. So we've done the bulk of this effort now, with many places still needing to go, still a tremendous amount of work. But here's a piece that people don't often realize, is putting the thing in isn't really the work. So I came to North Shore in about 2011. Remember starting back in 2003 or something over there. And it was really by about 2013 that North Shore was able to do the highest level of deployment of an electronic health record, including these predictive models built into the system directly driving care for a clinician. So that took 10 years. Now that was a pioneering health system in that, and so maybe it's faster in other places, but I'm not so sure. So if you progress that out and you don't make any assumption and say, well, they can only go about as fast as North Shore was able to go, then we get there now, 2015, 2016, we're arriving. We're talking about being able to do those things in 2026, which is totally unacceptable to everyone. So hopefully it can go faster. Then there's the startup part of this world, and so doing things in health IT in general and informatics has become extremely hot. These slides are also 1 year old, but it's because we're already down the tail the other side, so it doesn't really matter what happens over here. The point was already made on this one. With this tremendous spike about the same time in 2014, all this deployment everywhere, there's a huge amount of spending. And what happened in 2015, this is the amount of spending in startups, and then the number of deals is there. And so what happened is the number of deals starts dropping off, which means bigger deals are happening. Yep.
How much interoperability there is between different systems?
So yeah, so this is a topic that I was mostly going to conveniently avoid today, but thank you, Bob, for bringing it right to this front and center. And his question was, tell me something about interoperability between all of these systems. And so let me take a minute on that without risking going way over my time and getting back to the other stuff. So the general answer is that built into this incentive program was requirements for interoperability. But it was developed relatively late in the process, okay? And so as federal government things tend to go, the early part of the process is the only one that actually ends up hitting the street and is enforced and gets all the way through. And so what happened is the money really supported the rapid increase, in medical terms, a rapid thing is less than 17 years, right? Because a typical discovery in medicine takes 17 years to be deployed. That number has been demonstrated over and over again, and it doesn't seem to change, which suggests it's generational as opposed to something scientific. But in any case, the meaningful use incentives in phase 2 and phase 3 have all this interoperability, but they've been canceled. That's a short view of it. I mean, there's some experts in here that can probably describe it in more detail, but I think for our purposes, that's roughly accurate. Now, it's not all bad news. There are a bunch of interoperability things that did get in there in phase 2 and that are happening. But the problem really is not so much what the government incentives were, it's the need for the government incentives in the first place. Why isn't it of interest to all of the agents in the system to have interoperable data with them? And this is an incentive alignment problem So if you think about, I'll just provide one example I've heard many people say in medicine. If you run an imaging center, getting the previous images isn't of very much value to you, because if you don't have them, you have to run the images again. So as long as you're in a fee-for-service system, all of those actors that are selling product in the system are disincented to have interoperability. It serves the patient, of course. That isn't always who ends up getting best served. I would say there are some very positive things, and there are some developments in technology that are coming in the very large electronic health records that are changing from a sort of 1980s style database and custom interfacing between systems to standards. There's a huge standards community, huge in terms of the amount of work, not necessarily the number of people, in the medical space in HL7. And that has progressed through data standards that are actually not bad, through sort of a custom interface to an XML style interchange and to an API style interchange that really is now here. And it's going to start getting deployed in these systems over the next couple of years. And so there is hope. There's good progress on that. But the actual incentives kind of tailed out, and you could deploy these systems without really having to do much of it. Okay. So my assertion is that this is actually Chuck Friedman, who is going to be mentioned many times in this talk, is a close friend and colleague, and working with him quite a bit in this learning health system world. He was at the Office of the National Coordinator when all those meaningful use incentives were actually being built, and subsequently went to the University of Michigan to try and really do this stuff in a new academic department of learning health systems. But his assertion, which I support, is that in biomedical informatics, and probably in computing in general, the real principle is to make the human beings in the system better with the computing. And it's not a replacement, but to do the things that the human beings are not good at and make them much better at their jobs. So with that in mind, the future medicine that we're driving towards is evidence-based, and in that sense, it's data-driven evidence as opposed to consensus expert-driven, which is what we have now for the most part. It's practice-based, so generating data directly from practice. So evidence-based medicine and medicine generating evidence at the same time in a tight loop. It's much more targeted and precise as we go forward with genomic and imaging biomarkers, personalization, and getting us to this learning health system, which really is about getting the right care to people when they need it, but captures the results of all those transactions for improvement in real time. And of course, interoperability is critical to that because data is coming from all these different places. And even if it's not flowing back in, one has to do the data normalization from all of the various different places to put it together. So that is a substantial challenge. So what is this data that's in this health systems in a typical enterprise data warehouse? This is a particular view from North Shore over the next set of slides. So there's extreme granularity of data capture. Now, for many of you in the room, terabytes of data is not a big deal, but it is when it's all transactions. So, transactions that just say, so-and-so was seen on this date and time in this office location with this diagnosis. That in a little database stream in Oracle is almost no data at all. When you start to get terabytes of that, that's a lot of stuff happening. And there's a lot of networks and complexity and things built into that. It includes the demographics, medical history, orders that were made, what medications are given, surgical procedures, including details about external things like implants. So you could find out, if that implant is failing, in theory, you could get that back out to all the people and say, hey, you have this implant in your body and we're concerned about it, right? So there are immediately all of these types of things that can happen if the data is actually brought together properly. Test results, vital signs, and then a big one, of course, is the text of all notes. I'm not going to talk much about natural language processing here, but there's a rich, rich data that the clinicians write into those notes for not quite clear purpose, but nonetheless it's done. And there's a lot of data there. Okay. Yeah, please, Julian. David must have been talking to you and implanted this question. So Julian's question is, with copy and paste, you know, is the text notes, you know, are the text notes really of value in any use? And I have about 3 or 4 slides on that, which are coming up very soon. So I want you just to hold on to that one. So I'm going to hit that exact thing. So it was a great plan. So yeah, I would actually. Thank you. So, yes, so collection of discrete. Actually, it's on this slide. You said that right as I switched slides, I think. I think I was switching as you asked the question. There you are, collection of discrete clinical data. So actually, that's probably my first example after this slide, so you're even closer in time. So the point of this slide is to say, okay, what are things that we're able to do? And this came up as a collection of spending a few months at North Shore and saying, oh my gosh, you know, what's here? What does the system really do? What can it do? Who are the people? What are projects that we could do that would really make change? And I sort of classified them into these groups. The first group is the one that Julian was referring to, which is collection of discrete clinical data. Build a system that collects the data as discrete data, not as text, so that it becomes computable right away from the beginning, and it's much more useful. Its context is known, its detail is known, its numeric or choices, things like that. Integrating with other systems, which is actually related to Bob's question about interoperability. This isn't really an interoperability question, but a custom workflow built in the system. Surveillance algorithms, monitoring things happening in the system where there are known things that we want to do better, things that we know about, but we just miss. And then the predictive algorithms, which are the pinnacle where we're using the data to compute algorithms that are based on the data, that we actually recommend things for people that we're not really sure if they're correct. There's error bars around them, and they're typical predictive models with statistical variance. So that's sort of the whole mountain of stuff, all of which we were able to do in many ways over those years. And by the way, this one, there's a Health Information Management Systems Society model of deployed functionality of electronic health records that stacks higher and higher functionality, and this predictive algorithm is the one that's at the top that we did for the first time in one of the projects I'll mention in a commercial EHR on the outpatient side and then on the inpatient side, which allowed North Shore to remain in the lead position nationally in terms of deployed functionality of electronic health records, the first place to do those things. And so it is next, Julian. There you are, the very next slide. So here's the problem. Clinical documentation is this rich source of information on all these interactions between the health system and individual patients. But the question is, how can we capture this information consistently and completely for some purpose of analysis for the interesting parts? Okay, and so the answer really is we need this tool in this EMR to balance expressivity and workflow. So expressivity is how, you have maximum expressivity when you can just dictate anything you want into the record. You can say anything you want, but you lose all of that consistency and completeness you're looking for because people omit a bunch of stuff. And they say things in various different ways which you could never really reconcile. But if you create a workflow that forces them to articulate everything that they want to say in discrete data, they'll never finish their job because dictating is extremely efficient. So you have to balance this expressivity and workflow, and so this part of it is really an art. That is not, a scientific choice, it's an art. And so at North Shore, with 25 different subspecialties over about 4 years, we were able to build these tools that do discrete clinical documentation. There's a few ways that you can do this. Let's see if this thing does something interesting. Nope. All right, I'll use the finger method. So if you're thinking about research, the usual way is these blue arrows. Physicians type anything they want. a human person's reading that data, abstracting it, and putting it into a discrete data set that's planned in advance, okay? And so it leads to a lot of omissions because the stuff just isn't there. And it leads to a lot of misinterpretation because this stuff is written in prose and you rely on the interpretation of the individual. So it's 100% dependent on the strength and quality of these individuals that are doing this work, and very labor intensive, and the higher quality ones are expensive. So that's what we do, manual chart review. Tons of research being done that way. Where we naturally are heading is to taking this free text and running parsing and abstraction with computed algorithms. So this is HAL, a supercomputer from 2001: Space Odyssey, doing natural language processing, okay? And then feeding that into a database. But this doesn't actually solve anything because really this is just trying to replace the work of this person. So all the omissions and the confusion stuff, it's all still there. It's not really going to work, even though it could work perfectly. It really doesn't work. And so actually what you need, and this is to Julian's point, is you need the physician actually working with structured tools that generate the text that meets all of the billing requirements and the ability for people to read it when they want to read it, because you can't necessarily read the result of a bunch of pulls and pushes and things, checkboxes and stuff. So you create tables and you generate prose, very, very easy to do from structured data, and put that in the database. So that's what we did in more than 25 subspecialties, 15,000 new fields, millions of data points. And it's really just a problem of discretization, which is a computing problem in everything, right? Here's, it's a translation of continuous information into discrete data, then you can operate over it. So here's a few statements. Patient reports dyspnea. Patient complains of shortness of breath. Patient denies shortness of breath. So this is dyspnea, yes or no? And I would, with the clinicians in the audience all cringing, I would say, all the rest of this is crap, okay? This is all. Does a patient have dyspnea? Can I define this thing as something, and do they have it or not? Examination revealed crackles. The physical examination resulted in lung crackles, negative for lung noises. So, are there rails in the lung? Just give it a name and say yes or no. And let's move on and get rid of all the flowery stuff, okay? Because we have to balance expressivity and workflow. And so if we're going to succeed, we have to give up some of the expressivity and get down to what's really needed. I don't have the slide for that one, but the question is, how do you anticipate the novel stuff? So the art of this is to spend enough time with the clinician that you get an encyclopedic view of what it is they're doing. And then you have all of those places where you have the breakout for other. And so when you want to look at the interesting stuff, it can be there. But when you're computing stuff normally, you're just not interested in that. So that's the real trick on the balance of the expressivity. So the history of present illness, there's a few check things, and then there's a box that says, say whatever else you needed to say. And clinicians do a number of useful things with that. That's a place where they do customer relationship management and put in something about the kid, so when they open the record the next time, they ask them about their kid. I mean, that's okay. That serves real value in the system, but it's not a kind of a thing that we're likely to be using. So the other category, the text breakouts all over the place in this, serve that purpose. Deborah.
People explicitly study the validity of this, given how easy it is to lie. Let's do the checkbox on the slide.
So the question about validity is a good one. And there's been some studies, as you're probably aware, of the use of ICD-9 coding and whether people use ICD-9 coding to encode what they want the patient to have in order to bill correctly for the insurance versus what they think they have from a diagnostic point of view. And they clearly put in what they want to bill. There's no doubt about it, okay? So these things do create that kind of a problem. And I'll mention again on the hypertension project I'm going to talk about in a second. However, they say those things in free text. So I'm not sure that the conversion to discrete data is a cause for that, and particularly when it's designed by the clinicians for that. So I think that problem is very real in terms of the accuracy of what they're doing. Physicians sign off on all of these notes, on all of those coding, and they're making them as their professional assertions. And so it's a little unfixable.
Omission versus lying by omission. And so, for example, I'd be less likely to write pupils equal round reactive to light in a combination if I didn't test for a combination than I would once I click the box. It automatically types that to go and erase a combination.
Yeah. And so that's the art of it as well. I haven't put on any of these screens and showing these things, but there are certain places where we do have some tools that could potentially head in that direction. The way that we've tried to avoid it as best we can is doing positive assertions in a fairly granular way, number one. And number two, where you need to fill out a bunch of things in order to meet some regulatory requirement, we've allowed you to do the positive assertions and then click a button that says set unanswered to no, okay? Which fills out the other ones as they didn't have them, okay? But it explicitly makes you say that you checked them all, so that everything that you've done is a positive assertion. And the regulatory legal folks seem to feel that that's sufficient. I'm not sure it really solves the problem, but it's as close as we could get. So this is a paper that's probably, they're in the rush to do all this stuff in a very operational way. There's not very much that we've published about this, but to get a look into it from a publishing point of view, this is a very good piece describing where 8 of these 25 projects were in neurology, led by Jim Maraganori. And so he's a very strong partner in this. This particular paper defines this, talks about the program, and then how it's used for quality improvement in neurology as an important piece. This got a bunch of awards in the neurology world last year for this paper of showing what the future looks like. So I'm going to now talk about a different kind of data collection, and then we got to accelerate. So or not finish is another option. So this is a Genomic Health initiative. This started in May of 2014, which is about a year and a half ahead of all these applications for a precision medicine initiative, which many of you are familiar with. That was an effort to do a very similar thing at North Shore. And really, this is much more about integration of workflow than it is about anything else. Because over the first year, I think there were 8,000 and then up to 11,000 in 18 months of patients that signed up spontaneously on their own with nothing sent out to them to have their genome sequenced and associated with their electronic health record. And we think that was a pretty extraordinary achievement given the minimal amount of sort of on-the-ground effort. So I'm just going to describe this really quickly. So the idea was, okay, we have about 500,000 to 1 million patients, depends how you want to count, that are hitting the North Shore system in any given year. That's a wide range because you can count that in many different ways. But many of these people are getting their blood drawn. And so one approach was, okay, we just put somebody in the places where blood gets drawn at North Shore, but there's dozens of those places. So we just put someone in the biggest ones and said, hey, we're doing this study, you're getting a blood drawn today, can we draw this extra tube? And so we got the systems worked out and the kinks worked out doing that, and that made a certain amount of progress. But then we really accelerated the progress by coming up with an electronic system that was able to do the entire workflow. And so what it did, basically, it worked with the portal, so the electronic health record portal that people log into to get appointments and pay their bills and message their doctors and stuff like that. That's a pretty advanced system at North Shore relative to the industry. And it's ridiculously simple relative to every other industry, okay? But in that, we were able to put in a custom web page that basically had a multi-purpose consent. I would like to do this study. I would like to be contacted for future research studies. And I'd like to know the clinical information you find out in this genomic study or not. So those are all positive assertions, which took the highest ethical standard in that approach. And by the way, it was just a little flag, a little description, picture of Pablo Gejman, who's the PI of this thing, on the portal. There was nothing sent out. You said, hey, I'm interested in research. I want to work with that guy. And then you would get this consent and the description of things. So again, it was initiated by patients actively in every step. The challenge was we needed to flow that through the EPIC system to the phlebotomists that live everywhere so that the next time that person came in, the phlebotomist would say to them, I see you signed up for this study. We're going to draw that blood right now. That turned out to be a pretty substantial challenge. We had to write some custom code that made different systems integrate and work with each other. And it began working. And then we had to work out how those specimens go to the laboratory with a clinical label on them, but have to end up with a research label at the end. When they hit the laboratory, they know that the person signed up, the tube is there, but they've got to know what their research ID was when they consented, and we worked those things out with some more custom code. Got the whole thing through. So that's the sort of way to do that kind of a thing at scale. Another project I'm very actively working on, this is a paper that's, probably should put the paper that's coming out in AMIA. This is the one before that. But we have a paper coming out in AMIA this fall around using smartphones collecting data. So this is another way. Remember I said there's all these different data places. This is a place where there is very wide dynamic range data on an individual, like the genomic data is, in some sense. And the idea here is that you, with chronic monitoring in a smartphone, you can see differences in people's gait. And the question is gait physiology? And could you then therefore say things about a person's physiology from that? And the initial studies say yes, you really can. So what was done in the, I'm not actually going to describe this paper, but the one that we did together that finished this spring and is going to be published this fall. What we did is we said, okay, with this specialized gait monitoring system that Bruce Schatz at Urbana worked out with some of his graduate students, what would happen if we put that in the pocket of COPD patients? Okay, they have trouble breathing, they slow down. There's actually a standard approach called the 6-minute walk test that just sees how far they walk in 6 minutes. And you just measure that distance, and that's a measurement. Of course, it has tremendously wide error bars, and it doesn't predict very well. But if you put a smartphone in their pocket with 6 accelerometers that you're measuring at a very high frequency, much higher than it normally does as you walk around, because you can turn that thing up, right? That's a general computing device. You can make it do awesome stuff, right? So you turn that way up, you collect at high frequency data, you then put a big classifier around that, and you classify people into different ways that they walk, and we're able to predict perfectly what the gold score is, which is not a hard thing to do. It's only 4 categories, but it predicts what their relative status is when they breathe into a machine to measure what's called the FEV1 for the clinicians, and then it scored their level of obstructive disease. So that works perfectly well when you want to classify against those things. That would be gold 2. I don't know what's going on over there. Yeah, little aspiration. Yeah, he's just trying. He wants to be a participant in the study. So that really works, and it works based on all the things you might think might be necessary. First, you got to classify the data into groups. Then you have to do some voting algorithm, because every 10 seconds you check and see what the style of their gait is, and many of those 10 seconds intervals, it predicts the wrong thing, and so you have to do 85% of the time right. But when you work out all that stuff, it just plain works. And so the question then is, do you put this in people's pockets? You use a very low level of activity so you don't burn out the battery to figure out when they're walking. And when it says, oh, a person's walking right now, just turn it up and collect all that data and then turn it down again. That's where we're going. Here's an example now, moving on to surveillance. Remember I mentioned data integration, surveillance. I guess that last one was a surveillance example. This is a surveillance prediction example, and then a prediction example, and then we'll get through the other part. So this is something called what's going around. It doesn't project very well here, it looks like, but this is a sample from an application that was built at North Shore that integrates into the electronic health records. So you put a button in there that basically when you hit that button, it just puts a web page in the context of the application. So the integration is very simple, but that button tells you which patient, which is really important, right? Because what's done with that is a little blue dot comes up where their home address is. And then it shows you a map of the infectious disease incidents around the Chicagoland region based on the data from the health system from the night before. This turned out to be incredibly useful and powerful, and able to show actually a pertussis outbreak in a particular suburban area showed up on this thing, which was pretty interesting. The general idea here is give the physician a lens into the whole health system. Because what happens is when the flu season comes, we know kind of around when it is, but each individual practice waits until they see about 10 patients that are coming in with a cough and fever, and they give all of them antibiotics until they get to the 11th one, and they say, you know what, I've been seeing this for a while in my practice. You just have the flu, stay home, and they start telling people not to come in when they have a cough and a fever, right? But if you have the benefit of the entire health system, you can do that after the first or second day, which may be your second or third patient. And now we can stop that huge bump of use of antibiotics and make that go away. So there's a study that was run last year that's probably concluded now, and the data being analyzed to see if, in fact, that caused a reduction. Okay. So this last one I mentioned a couple times. There's this project that was the highest level prediction modeling. This was one that was done with a guy named Mike Rakotz, who you might know as at the AMA now, and Chad Konchak and Ari Robichek. And this was about seeing if we could eliminate undiagnosed hypertension. So about 25% of people that have hypertension, the diagnosis is just never made. And this has been proven again and again in epidemiologic studies. And it's just because there are blood pressure measurements in different offices, and it's not brought together, and you run up the stairs, and you're sweaty that day, and the physicians just discount all this stuff and say, well, you know, it's just a high blood pressure, don't worry about it. You get in the dermatologist's office, you get in the surgeon's office, ophthalmologist's office, and it never all comes together to say, hey, you really need this thing addressed and treated. So, but because it all flows into one place, we're able to look into the data warehouse, find those patients that were likely hypertensive. Mike Rakotz, through a sneaker net, went and called 1,000 of these people, brought them in, measured them carefully to get outcome data, and then we built an optimization routine that we were able to put in as a predictive model that runs whenever blood pressures are measured. There's two interesting things on this. One is that the initial model was about 38% positive predictive value, which we thought was great. And the clinician said, you're not putting this in unless it's 50-50. Everything, anytime that thing flags, it better be the chance that there's at least 50-50 chance that person has hypertension, or you're wasting my time. So we had to readjust the algorithms. RLC curve is your friend and not really a problem. Just adjust it to shoot 50-50, but then you leave a bunch of people on the table that meet the medical guidelines. So the quality people got upset about that. So we had to create a separate system that would run and send to the practice manager all the list of people that met guidelines, whether they were in the office or not. So you end up with these very interesting integrative problems that you have to deal with, and you have to be prepared to deal with when you go in to solve these things. This just shows, you know, a quick eye candy graph of people being diagnosed with hypertension, a test of the system in a practice area which we knew had a lot of undiagnosed hypertension, or we suspected would have, and then the regular run at a higher level in the system after that. Okay, the last piece that I'm going to blaze through too fast. We had some questions along the way, so I'm going to extend a little more. Yeah, I'm going to go a little into the question and answer. Yeah. Then I wanted to talk about this learning health system concept. And this is really something that was driven hard. Remember I mentioned Chuck Friedman. When he was at the Office of the National Coordinator, he commissioned this report by the Institute of Medicine, now the National Academy of Medicine. And really this was about what digital infrastructure is needed to begin to have these learning systems like this that use data running at a nationwide scale. Actually, Ian was one of the folks speaking at this workshop, as a matter of fact. And it's really to drive the process of discovery as a natural outgrowth of patient care, as a general idea. And I got linked up at that time with this fellow, Joe Cantor, because he then sponsored a meeting to bring together a bunch of stakeholders. And so a lot of the work that I'm doing is related to his foundation, which has a mission, a vision, not important. There's been many things written about the learning health system, that report, things in the New England Journal, others, and it's becoming a very popular notion. But here's a couple of views of what it is in a very discrete way from Chuck and from myself and from those that are really driving this learning health system concept. So this is a checklist view. Checklist view is every patient consenting to that you can learn from their experiences, or do they not need to be consented because they're expired or something like that? Is the best practice knowledge immediately available to support decisions in care? Is the improvement continuous, so that data is continuously improving and not just fixed in time? And is this happening routinely and economically and almost invisibly in the system? And this is part of the culture of the system. It's expected that this has happened by patients, physicians, all this. This is where we are when we're at a learning health system. We turn into a much more rapid cycle of learning. So here's a microscopic view of how that happens rather than a checklist view. So we have this problem of interest, and we collect data about it. We assemble the data, analyze it. We got some results interpreted, but what we do typically in science is that results in a journal publication, and that's the end, right? Instead of that, we want that to drive back into delivering tailored messages and care, taking action to change practice, and then deciding to study it again and go around the loop continuously, tighter and tighter. That's what we mean by a learning system. And they can exist at any level of scale. So you have in one organization, I mentioned some of those at North Shore, many organizations, a region, or worldwide. So we can all think of many value propositions of this. I'm going to skip past that. This is 105 endorsers of the principles I'm going to put on the next page. So one of the things we did at that 2012 summit that was sponsored by Joe Cantor is we got together about 50 organizations, maybe 80, and had them all talk about what would be the principles behind a learning health system if it was going to exist. And that was taken up by all of these 105 organizations that have subsequently sponsored those 10 principles that came out of that meeting. And those 10 principles basically, in one slide, it's about a 3-page document that they've all endorsed. Talks about being person-focused, managing privacy, being transparent, adaptable, enough leadership and governance to make the thing work, scientific integrity. So amongst these principles are very mom and apple pie, and that's how you get 105 organizations across the industry to sign up. But that's where it's sort of happening. We're having a meeting in December to say, okay, assuming all these organizations are on board, you're going to now come and tell us what actions that you would take that change your organization and head you towards being a participant in the learning health system. So that's the next step. There's a new international journal Chuck is leading, and I'm an associate editor of Learning Health Systems. That's open access, and it published its first paper, I think, 2 weeks ago. And then I'm not going to talk about some of these networks of things other than to mention them because I'm over my time. And they may get mentioned in some other speakers today, I'm not sure. The Capricorn Network, many of you are familiar with, is part of the Patient-Centered Outcomes Research Initiative. It's an effort. This is a particular Chicagoland one that's part of a nationwide one of 60 groups like this. To bring together data for outcomes research. The Epic Systems, which is the leading electronic health record vendor, has 340 health systems around the world. I personally led the effort for several years to get them up to a research network to do this kind of thing. They endorsed all of these many principles as the way that they're going to approach bringing data together. This is their version of those same principles. And that's often going. And then one activity the foundation is doing itself is bringing together data from folks that are dead. It turns out there's a safe harbor in the HIPAA law for using data from people that have died with research that allows you to have their identifiers. Whereas the regular safe harbor for everyone else is de-identified, which causes all kinds of problems, right? Because you can't link to other data and all kinds of other things. So this is, the last slide is, why do we need the patient identifiers in order to do this research? And so that's a significant approach. It basically allows you to chart things in the context of time and location, which turns out to be really important. And then if you can do that, then you can make assumptions about the behavioral characteristics that are not in the EMR based on where people live and at what time. And I think that's it. So there's a few more question time. I'm not so far off. Okay. Bob. Oh, you're killing me. Okay.
So in a context where different health systems live in a huge advantage to have patient action. Therefore, huge disincentive for data sharing, for any. So in there are many scientific disciplines where you have similar issues.
Yeah.
And where interoperability tends to be enforced and encouraged by kind of the basically you don't get the grant renewed unless you've made the data available in some standard way. So what's the story in that?
Well, I think, so Bob's question is you know, many domains have this problem where data sharing is not in the best interest of the data generators, or it's not, they have greater interest in not sharing, let's say. And so the federal government steps in and helps with that. And so I mentioned earlier the meaningful use provisions were really the answer to that, and in a very similar way. And it's gone some distance. I think what's happened now is we've started to see the beginnings of that being enforced in another way, which is another big part of the Affordable Care legislation relates to how payment occurs, which is another important incentive. And the way payment is occurring going forward relates to outcomes and relates to managing a population so that you now become at risk for providing the most efficient care possible. And so if you now have a responsibility for this person, you better get the data of what happened to them at the other place. So that has the possibility of improving this, and we're starting to see that. But it's a long road. And so I do think there will continue to be some legislation around data sharing. It's certainly the case that all data has to be shared with the patient. The patient's request, that's gone through. They've had to do that. Unfortunately, they're doing that amongst different standards and not in a way. Plus, there's a trust factor of I've released the data to the patient. We don't know how it's been manipulated before it's been handed back. We would like it to go from one professionally managed organization with legislated and signed relationships of assertion of the validity of the data to another one that does the same thing rather than out to a process that it doesn't have a trusted framework, even though, you know, it's a funny thing to say because it's in the patient's best interest that the data is correct, but you can understand that we don't know what happens. So I think there are these technical requirements and there are monetary incentives. They're working their way slowly through. I think what's happening is we're starting to see some value propositions for the systems, but this is a bit of an optimistic view. Those are starting to have some impact. So the nursing homes are saying, okay, listen, you have to send us this data to take care of these people that you've sent to us. Patients are beginning to say, I'm tired of carrying this data around. Will you please get it to the other providers? And so there does become a patient satisfaction element to this and an expectation. So these things will come and are happening, but they're slow. Go ahead, Laura. Yep, so the question is comment on collection and management of race and ethnicity data in these systems. And I would say, as we all know, there are many problems with that data. There are several different standards of how it's collected that's changed over time. And if you follow the most disciplined one, they're a little bit complicated for the average person to assert sitting at the administrative desk when a person walks up to the health system and they want to check in and make sure they can see their doctor, right? And so I think, I'm not an expert in this field, but I've looked into it some, and I would say it seems to me that the highest standard is self-assertion by the person, not by observation, right? And so it's generally done by observation, which is a big problem, right? That desk clerk is just saying, oh, well, this is a Hispanic person, this is a, you know, they're not asking the question because the question is offensive or whatever, right? So we've got this data that's collected that's 20% other or 20% unknown, and then the assertions are not done at the highest standard. So this is sort of the standard that we got. It's interesting, in the portal for North Shore, you can actually find your way in and change it for yourself if you want to, but it's awfully hard to find. It's certainly not promoted. So the current state of the art of that data is it's weak, and it's not following the federal standards. The opportunity is absolutely there. Again, there's an incentive problem. Why is that collected? It's of value to the researchers that focus in this arena, and they don't have the leverage to affect the day-to-day workflow of the health system, and so you don't collect the data very well. Sam.
One EHR vendor that Epic will not come to the meeting, and Cerner will rarely come. And so what's the value of having a discussion about how important standards are for, this was clinical trials, but if the vendors aren't going to participate? So what's been your experience with them around this, to bring closer to the vendors?
Yeah, so I think the vendors are very challenged by these large meetings, and so the Epic folks and Cerner and others have endorsed our learning health system stuff, and so we've made real progress in there at the conceptual level moving down. The problem is that at the end of the day, they always have to deploy stuff that's generalizable, will work across their clients, that fits into their development model for something related to their product. That's what they do, and so they'll only tolerate the meetings enough to collect the information to suggest, okay, here's what I'm going to do. Here's what I'm going to do to solve that. And that's a tough problem. You know, nobody's wrong in that problem, but that is the problem. And so I think you can break through that. I mean, we've had success in demonstrating to them the value systems of those things, but it comes from taking the output of a meeting like that, and I'll be happy to do this with you, then take the output of the meeting for that, you know, knock on their door, go up to Madison and Verona, Wisconsin, and say, hey, listen, here's the output of a bunch of people that were there. How do you guys want to approach this? And they'll answer, and they'll solve it. It won't be exactly what the consensus group said, but you'll get a lot closer.